going to leave the slides here. I always leave my slide anywhere. Some people are very prescriptive not to do so. Because slide you can read, but what I'm speaking you can't, unless you are recording it. So the improvisation is a military word. When they don't have resources, you do something. You put instead the splint, you used to put the rifle next to the broken leg. You put some two bamboos, make the stretcher with the ground sheet, etc. That was improvisation. Next word came after improvisation, jugaad. How many of you read book called Jugaad? Oh, lovely. No, I am not expecting teachers. Lovely, two of them have read it. Good. Jugaad is the book which became bestseller, and 3 Indian US citizens have written it. And it is known to the Western teachers that what is that jugaad? Jugaad is this. You can read it, I will not read it. How the word jugaad came, anybody? Because when I wanted to write a book, I thought for 2 years, I traveled around, looked around, made friends, created some 25,000 people on email, collected a lot of things. So how jugaad came? Anybody? In Punjab, when these oil engine became useless because the electricity had come, so one of those automobiles mechanic type fellow, he said, what do I do with these engines? Lots of them, nobody is buying it. So he created a jugaad. 4 wheels, steering, and carry on boy. And that was the first word jugaad was used. And the context, whatever. No safety measures, it is having a complicated issue with their own solutions, etc. And that is what technically these definitions are known. You come to innovation. This is the exact definition. There are many, I thought I was better. That innovation is process of translating idea into, and then it is, people are ready to buy this, and it has some economic cost. What is the difference between invention and innovation? Invention is very scientific with all that. Just to give an example, in 16th century, the steam engine became an invention when it went on railway track after industrial revolution. Today, creating all kinds of train, Rajdhani to electric to whatever, that is all innovation. Now, this is my last preliminary slide for the younger lot. What are these definitions of frugal innovation? Frugal innovation, India has known, it is out of necessity. You create innovation because you are hungry, you want to do something for your daily living, and such is called frugal innovation. Plenty in India. Second is reverse innovation. Govindachari has written a book on reverse innovation. And reverse innovation is that you create something, it goes abroad, they further refine it, etc., come back to you at a higher cost. That means you are creator and you get back as a reverse. Third is a disruptive innovation. You bring something to the market, everything gets disrupted. Mobile technology and telephone is one example. That everybody now wants to carry this. And when I was initially bought one, I came from United Nations. I was flunging around, not I required it. 23 rupees a minute, I still remember. Today, I don't think anyone else was to show because driver to maid, everybody has got it. And that has disrupted more mobile in India than really this static line. Fourth one is innovation. There's a chapter in my book called Innovation, because I have seen the book is already there in your department. I've seen it, they bought. This is when Indian innovations were so many, and World Economic Forum has accepted the terminological innovation. China has bid for it now, why not Chinovation? It has to anyway. So now I believe they are also accepting. The last one I have also written a lot about innovation excellence when a department, organization takes it to next level and aggregate these innovators. Now we come to the business for which I have been here. We have already talked of innovation, and innovation we talk about. There are different tools who are two sides of the coin. Lean is one, process innovation, it works, how to, what is the really requirement of these innovations? Requirement is to reduce healthcare delivery costs, yet keep the technology, yet keep the quality. And I do these projects all over lean. Kano is a famous Japanese management fellow who brought the word called delight. What you are doing today and something new to the customer or a patient, that's a delight. But you have to, that delight becomes routine and you have to bring another delight. One example, take a blood specimen. He comes to you, your house, 50 rupees, take it, and the lab reports on internet and you can access it. This is the delight when it came. Now to be in a business, everybody does it. So you have to find, so innovation will be part of all this. Clinical pathways and evidence-based medicine. Everywhere in that, how using the technology, you can take the next step forward. I will not go to that much of a detail because in IIT Kharagpur, we have run the course for 10 days on healthcare innovation. And we were 2 people who were running it. And now we have another course of 5 days, 3 days, 1 day, etc. Cost optimization and sustainability. I've written a lot on cost optimization. My predecessor speaker also used affordability. WHO have written, there's nothing like affordability in healthcare. A fellow on the street can't afford, so how can it be affordability? He has to be subsidized by insurance, by government, something. And each healthcare delivery has a cost. We can optimize it by all these models, etc. So WHO discussed it, he said it makes sense. But that is all. I hope they will say what it is different to. Now, yeah, there's a very famous model. I'm a doctor by profession, and I feel proud of this model. But when I go and teach or learn somewhere, input, process, output, in 1956, Dr. Donovan, who was a public health, created this model, wrote 16 books, first created healthcare quality definition. And his name is not known. Automobile will say, this is our model. When I tell them, this is not your model, this is a doctor's model. Input, what all we are talking. Process is the one. There's a, automobile says it is 80% waste as per green theory. We say it is 60 to 70% in the health sector. Everything can't be removed like robots. And output is what patient is needing it. He's not interested in anything. He's interested optimize costs, best, etc. I think when you talk on optimization cost, the innovation in different sectors, right from the hospital planning and designing, which is one of my very good expertise, we created such one hospital in Kolkata. And my next book is in hospital planning and designing, a lean, innovative, evidence-based design, which will be available in October. It is with the publisher in the US. Now you would find when you want to do, you have to take help of the technology. IT people are everywhere. And they will, you say flows, then you have interdepartment relationship. I've used earlier days my operation research as a MHA dissertation for interdepartment relation, and then create a hospital. Now ultimately, what is this supposed to be? That means first, you have flow diagram, think of functions, think of what patient needs, how it is needed, and then you design a hospital. I'll just give you one complicated. We took 9 months to make this particular hospital nursing network. You can't really see, and there are 12 different modules. We have inventory management. And somebody you're talking in that side in the morning, in this hospital, we create discharge in 15 minutes, Kolkata. And we have created, just wanted to tell you this, 20% reduction of cost. We have round the clock control room there, which controls, if nurse has not given the medicine, it beep, beep comes there. And every time she touches, it billed to the patient, reduced from the inventory, and at the reorder level, it goes to the dealer. It is there in India and Kolkata. So this is possible. I was listening to this. So, okay, thank you. No, it's okay, don't worry, I'll finish in 5 minutes. Yeah. Okay, So anyway, so I was all looking for my students better than anybody. We can talk anyway. Yeah. Okay. Now you find that these are the places where you have all kinds of this. In fact, 18, 19 September, as Professor Arvind has said, we are getting European Union, 14 companies, how healthcare innovation of all these categories can bring down the healthcare delivery cost. They are doing it. Now, I would just want to tell you that many things are happening. By saliva, you can have blood glucose level. It is there. Technology is there. You can have eye pressure. And the cost also we are thinking. Now, ultimately, what is going to happen, we are in touch with IBM. They are also coming to the conference to talk. CEO Guinea has said, in 2 years' time, I'll make all radiologists jobless. Ravi Khosla is a billionaire, a Silicon Valley, and I had a tiff with him in one of the conference. Computer can do anything, I don't need a doctor. So software will be everywhere. 5 to 10 years, you will find that. Like Kodak's story of 98, 1,70,000 workers, and they become bankrupt because Stephen, who was their employee, has created digital technology, and Kodak said, forget it, 85% market is with us. And ultimately, he created, and after 3 years, digital technology came, and Kodak became bankrupt. You don't need to be a B&B, Airbnb, a hotel fellow, Uber fellow. They don't own a bed and they don't own a taxi, but they run the business well. So we are into fourth industrial revolution or exponential age. And tricorder has something which has become up, 54 biomarkers, retina image, they can produce. Swasplate by PHFI did it, 26 different things. Didn't become success story. Doesn't matter. So you have to change to the ways of 21st century if you want to be in business. And doctors are there good in IT business. They are hired by them. Some have their own startup. So younger lot, don't worry, 70 to 80% jobs will disappear. Yet you can have for alternate job. For that, we can still talk later. I'll finish, I promise. I've got 3 more slides, that's all. This is one, Dr. Mukherjee is already doing something on the funding, but government is also doing a lot of things. IIT Delhi has one such incubator. If you have an idea, you get a 5 lakh rupee immediately. One idea is matured after 1 year. In the incubator, they give you 50 lakh, and you give only 5% of equity. We are in a grassroots innovation. We have done something in Gujarat, got National Innovation Award for that. And there's a Dr. Gupta from IIM Ahmedabad, along with people go, and they bring something. They are put into the Rashtrapati Bhavan. If they are selected, they have dinner with Rashtrapati ji. And you can see in the march, and you can see one fellow brought a drone, and he's the one, 14-year boy. Rashtrapati liked him. He said, no, you carry on for 3 months. And then funded everything. Opportunities are there. Dr. Mukherjee will tell you how to get money. I'll also tell you a little bit that there are money. 5,000 crore in National Innovation Fund started by the previous government. Sam Petroda was the one who was written a note for my book. National Health Resource Center, load your innovation if you have, and then it's funded. In my conference, I have a National Innovation Award. Professor Mukherjee, catch hold of him, he's one of the jury. If you have something. And IIT IIMs have the club, you have created a club, probably one. And all these private institutions. This is what I've quoted in my book, that you have an idea in the morning, I'll not read that. I don't know to waste my minute. And in the end, by lunch, you can achieve what you want to. A great thing. Now, what we are really achieving, we want to give a patient safe, effective, patient-centered, timely, efficient, and economic. There's a difference between effective and efficiency. That definition, you can Google it. So that's there. And this is what people think of India. It is not what people thought earlier. And this is it. And I can go on and can keep telling that there's a Harvard Innovation Award winner, Sathi was a project, Amrita got it, first 10 innovators, got $50,000. She created from banana fiber sanitary napkin because very low cost. And there are hordes of such case studies which are available that people are doing it and taking such advantage. There's a book, Think and Grow Rich. Please read it. Have your dream, money is there, and you can achieve it. We are already, sorry. Yeah, this is my contact address. Anybody want to know more? We'll have you, and I get around 200 mails, and I always reply myself till I can't do it, and in future probably somebody else will do it for me. We have annual conference, we are doing free webinar, write for the magazine, as I already said, and club, etc. I'm already talking to your dean, and something here will also happen. Thank you very much.
Thank you very much, Admiral, for a fantastic talk and sharing your insights as to how we can go forward with healthcare and with your own experience. I think it was very useful. The next speaker is Dr. Shyam Vasudeva, MD, for us. If you can come and talk about innovation in healthcare, I mean, innovation in medical devices, that will be fantastic. Thank you.
So after hearing to such wonderful people, I am really honored to be here sharing this dash. Firstly, let me share some of my thoughts on innovation. I'm more talking about not how the innovation and all that, but what I perceive and what I practice. So for the last 6 years, I've been working with healthcare, making healthcare affordable. So one of the most important thing what I use as a reference is a WHO report which came out in late 2011, which says that there are 4 A's to manage the mismatch in the healthcare system. Okay. So managing the mismatch in healthcare system, the 4 A's are: the first A is affordability, the second one is called accessibility, and the third one is called as availability. That is, when you may have all the technology, but when there is no power in the house, and then you have a defibrillator, it's of no use. Okay. And the last one is what I am really excited about, and I'm still learning that. I'm trying to use that in all my innovations, which you will see. That is called appropriateness. This is the most tricky part of this, all the 4 A's, the appropriateness. We always tend to, keep on developing something very, very advanced, much more sophisticated. And of course, it goes on becoming more and more costlier and running away from the affordability bracket. So the appropriateness is what appropriate technology, appropriate setting, appropriate application, all these, is what is the most challenging one. So let me quickly get started with the concept of how today's healthcare sort of innovation in medical device space, Dr. Ji talked about the pharma and biotech, whereas I'm talking about the device space. So if you see, the entire thing is now concentrating on the mobile, okay? The mobile or mobile attached devices or whatever. So the focus is definitely the mobile phone, smartphones, iOS, Android, whatever. And what is really important here is when we talk about healthcare, you have to see to it that this is extremely easy to use. We are trying to see now, we are trying to put some of the basic things into the hands of health workers or in the hands of individuals, in the hands of people who are old. So you need to now think about a very, very good user interface, and that is the most difficult part to design, I would say. And of course, connectivity comes with the device, and then how do you ensure that this is the user interface, the connectivity, everything works. So you need to do a lot of testing, lot of validation, lot of validation. 10% development, 90% validation. Okay? Not only that, you have to do validation on bench, you'll have to do it on the field also. And that is the device part of it. That is the device challenges. Around the device, you build apps. Okay? These applications are clinical applications. This is something where, you know, we have interdisciplinary sort of teams which work together, and these apps are now invariably cloud enabled. Okay? All these client server, all these architectures are all gone. It's all cloud enabled, and you have a big opportunity now. What we see is how we make it machine to machine communication, and also, you know, how you integrate that with social media. The new generation of applications, you will see, it's all integrated into the social media. Already, you know, we have, I used to work with a company called Philips earlier, and we developed something like Fitbits and all that, where, you know, we created a community of walkers, a community of people who jog, a community of people who swim. And then, you know, they benchmark themselves, and the one, you know, who is a lazy one, you know, will be woken up early morning by the others, and then, you know, pulled into this jogging or swimming, you know. Such simple thing to motivate them to keep themselves fit. Okay? So there are a lot of applications which you will see coming out. And then on top of that, what we do is services. Today, there is no device, you know, if it doesn't have connectivity, it has no value. And what do you do with this? You offer services which across the platform, like for example, everything, you know, is PPP model, okay? That is public-private participation. So when you are running a PPP model, you are not selling a device. You are basically selling a total service. And for that, you know, you see that is what you will do at the service layer, okay? So this is the model which I applied for all my products. So coming to the first one, that is in ophthalmology. I'm sure a lot of you here would have visited an ophthalmologist or an eye hospital. And what you see in an eye hospital is that there is a lot of equipment. I specifically started with this just because ophthalmology is one practice where, you know, you need a lot of device. Okay? And for that, what you see is there are devices, you know, there are specialists for each of this. When you enter the eye hospital, there's somebody, you know, will be a slit lamp, you know, there's an ophthalmologist sitting behind a slit lamp, examine the anterior part of the eye for cataract, infections and all that. Then they move you to the another device, which is basically, you know, there is a optometrician, there's another specialist. He or she will be looking at whether you have short sight, long sight, all these, you know. And then a nurse will dilate the pupil by just putting one drop of this one, and make you wait for half an hour, and then they put you on another device, which is now going to see the back of the eye. That is the retina. And, you know, pupil is very small. It can be, you know, as small as 2 millimeter there, you know. So you need to dilate it so that, you know, you can see the back of the eye. So that is a procedure which is actually a little cumbersome because you can't take it outside the hospital. So what we see is that is one of the problems. And then also intraocular pressure. This is a technique for a lot of them have glaucoma, and for that, you know, the only way to measure that was intraocular pressure, and that's why you have a non-contact tonometry. So if you take all these devices put together, it needs a lot of power, it's also costly, and you cannot move this outside the hospital. One of the big things about affordability is, can we, instead of patient go to hospital, can the hospital go to the patient? That is the paradigm shift, you know, we are trying to bring in here. And for that, you have to move this outside the hospital. So for that, we said, okay, can we not do something about it? You see, I have intentionally marked some green rings around this, all the devices. What that means is that basically this is a imaging system, which is either looking at the cornea or the retina. It's having two focuses, and it's all of them have similar thing. They have a stand, they have a chin rest, they have all that. Okay, so can we not optimize all this and put it into one? And that is what we did. So this is what is Trinetra, as what we are marketing, and you can also see one which is there in the stand. And that has all these features put into one device. It's a simple webcam. It's a simple webcam with minimal optics and LED lighting. So with just 6 watt power, we can operate this device. So I can take it to anywhere, put a small little solar panel, A4 size solar panel is enough to energize this, and start, screening people. And the best thing is, if you go to an eye hospital and get all these tests done, it will cost you anything between 750 to 1,200 rupees. Not only that, it's also going to cost you 4 to 5 hours of time because your pupil is dilated. Whereas in this case, we took out the procedure of dilation. It's a non-medriatic device. So that means there is no eye drop needed. And now, I can do all the tests in just 5 minutes. And the person can leave. All the data is integrated because it's only one device, so all the data is in one place. So report is also instantaneously generated, and then the doctor need not go to the village. Now the doctor can be sitting wherever they are, and they can report remotely. So these are some of the things, which put together makes it a sort of a disruptive innovation, okay? Because it's changing the behavior of the people, okay? So with that, these devices are in the field. All the information is uploaded into the cloud. The device is so easy to use that we can train drivers, to operate this device. The machine will tell whether the images are of good quality or not, all that, And then these images are uploaded into the cloud through the mobile network. And the doctor on the other side, there's a triaging engine which will decide whether there is a problem or no problem. If there is a problem, whether it is a glaucoma case or a diabetic retina or cataract. Depending on that, it is triaged to the corresponding doctor. And they get an alert through an SMS and also a mail. So then through any form factor, they can report from wherever they are, and that generates the report as it is shown, at the bottom you can see the report. So it's an integrated report what you get. So this is the system what I was talking about in the first slide, okay? And with this, we see that there is a device, and this same mechanism can be extended to other services also. One of the things what we realized when we went to the field is, this device, even though it has all the features built in, it is only adult-centric. Kids, school children, they have problems which are not predominantly retina focused or anterior sigma. It is more of refraction focused, and there we see that how can we do these tests? There are 20,000 ophthalmologists in this country, and if you are talking about early detection or prevention, we have 1.26 billion population. Even if you want to test one person every year once, you can imagine this 20,000 ophthalmologists are of no use one. In pediatric, it is much more worse. We have roughly around 200 pediatric ophthalmologists, and we have more than 200 million kids in the age range up to 8 years. Okay? So there, the mismatch is much higher. So that is where, we said we took the next case. Looks like, okay. So this is, this is another slide to just show you that, once you shift the paradigm from patient go to hospital go to the patient. There is a hospital outpatient department, I would say, go to the patient. You see, there is a whole lot of new mechanisms by which you can reach them out. The mechanisms like, you have mobile camps, you have GP office, you have you have the medical camps, okay, which are done in rural areas, vision centers, and so many of these, optical stores. We can put this device into various places, and we have deployed them in all over these places. We have today more than 1,500 installations in the last 4 years. And we are not only in India, but also, what you do in India, I can promise you, it is like driving in on Indian roads. Okay? If you drive in Indian roads, you can go and drive anywhere in the world. Exactly like that, we got this product done in India. Today we are there in 25 countries, okay, with this device. And that is the thing which I wanted to tell in this slide. So going back to my pediatric ophthalmology case, if you see, this is a very difficult task to detect these problems, early problems of squint and lazy eye, because this called as amblyopia and strabismus, this causes refractive errors, and it's a cyclic problem. If it is not detected at the right time, it can get only worse. So that is where we needed a special type of a mechanism by which we can detect and also cure. Cure is something which is only training muscle. It is like rehabilitation. Okay. So if you see at the bottom, there is these three images. The kid there, if you see, has a squint, and then it is important for the doctor to identify which is the eye which is dominant, and the dominant eye gets patched with a simple 5 rupees Johnson & Johnson patch, and leave it for 1 week, then remove the patch and again check whether there is an improvement or it is totally solved. So like that, if we do the patching and unpatching session for more than 5-6 times, the baby becomes normal. And then the refractive error also vanishes. So that is the first step, which we need to do when the kids are having refractive errors, rather than giving them the refraction at the beginning itself. So these sort of things are something which we could achieve out of another device. This is using a principle of photorefraction. This is an idea we got from the red reflex cameras, and with that, with some of these pediatric ophthalmologists, we developed this. And with this device, a worker at Anganwadi can take this device and do the screening at homes for these kids, and they can then the doctor from remotely can report on that and see that the treatment is actually administered. So a similar sort of a thing for pediatric, that is much more earlier case. That is, we have around 27 million births happening every year in India, and we have roughly 4 million of them who are preterm babies. So for the preterm babies, they are at a very high risk of getting blind, a small percentage of them, but still it's a big number. And they get blind if they are not treated for this ROP, a laser treatment within the first 6 weeks. So for that, it is very important to detect this problem at an early stage, and wherever the neonatal babies are born. So for that, we made a device, and this is a complete workflow. It is not just detecting the problem, it's also a workflow, scheduling the treatment time. The doctor who does the treatment is different from the one who is going to report, all that. The entire thing, workflow has been also developed. And with this, we are in a position to come up with a mission of eradicating blindness due to ROP in Karnataka to start with. Today, we have at 37 neonatal centers in Karnataka, NICUs. We have this program going on, and we are seeing that how we can eliminate it. Yes, a retinopathy of prematurity. So what do you do after detecting? That is, in ROP, we have said that laser is the way to treat it. So similarly, for diabetic retina also, laser is the way to treat it. So is there a way by which, should all these people come to the hospital for treatment? Is there something which we can do at their doorstep or closer to the patient? So that is what we are trying to see. Going forward, we are also developing some technologies through which we can do laser-guided therapy for this, and that is the next thing. And also, we are also seeing how we can make this a little more de-skilling or program, so doctors, even junior doctors can also do this treatment. So that is through image-guided therapy. So with this similar concept, I went to do nephrology, and then in nephrology, we know that chronic kidney disease is totally asymptotic. So is there a way by which we can detect CKD at an early stage? If we can detect this problem of CKD at an early stage, you can have some app or something which will actually help the patient to manage the CKD and also give alerts. And with that, we can see that we extend the life of kidney. And that's why we call this company renal extension, renal X. And we also make, for those unlucky ones who end up, with the end stage, we also make a dialysis machine which can be put in rural areas. So that's going through clinical trials now. So this is how it is. So this is the early detection, that is a reach. disease management, the care, and then the device, the dialysis machine. So this is fully made in India with a lot of collaboration. Last 4 years we have been working on this. And finally, how do you deploy it? So we have the health workers having all these early detection kit in their bag, and then they go door to door, and they are in a position to do the screening. And this is something, yesterday it was very nice to hear our Honorable Health Minister say that we are also, the government is also going towards this preventive care, and these health workers, they will get paid for doing the tests. And that is the only way we can sustain these sort of programs. And this is for a cardiac emergency, which my friend Gautam will talk about it in the next slide. And this is my last slide. So ultimately, all these, how do you realize that? That is where, we have a platform. There's a health platform on which it's a totally cloud enabled and has an IoT interface to all the devices, and it has interface to all sorts of files and all that. And it has both two important components. One is the e-learning, because ultimately you have to train the technicians, you have to train the doctors, everyone, no? So that you have a e-learning component on that, and you have machine learning through which, we can actually do this task shifting or de-skilling, I would say. The doctors don't like that, but what I'm going to say is there something, which the senior doctor was doing, a junior can do right from, a few weeks itself, not wait for another 3 years to learn all the skills. So those sort of machine learning can be done on this platform. It's all on open source. It's on Adobe and all that. And then we have a couple of applications which we are running on top. Okay. So with this, I come to the end of my presentation. Thank you.
Thank you very much. All of us enjoyed your talk, Dr. Shyam. Fantastic work, showcasing what we can do to retain, improve the eye care of people, and then having products in India, making them accessible to people around the world. Our next speaker is Gautam Murray. We're looking forward to your talk on innovation in digital health. I guess it's continuation of Shyam's talk. Yeah, thank you.
Good afternoon, everyone. It's quite a privilege to be referred to by such stalwarts and then following them up, to a talk. And hopefully I'll do justice to whatever being said and done. So my talk essentially also allows you to peep into how entrepreneurship kind of goes through a difficult task when you're trying to do innovation and the whole of digital health as an aspect. So one of the main things that you've seen is how technology, and in this case, I think the clearer picture of technology is always now the mobile phone. And why not? We'll see why not. When you talk about digital health, I'm a bit perplexed. I'd like to give some background. It's been 10 years I've been doing what I'm doing right now. And of course, my pioneers in this field are people like Dr. Shyam. But we've seen the definition of what we do change by people who are not doing it at all. Okay, so including the governments. And if you see, you have 3 distinct stabilized healthcare fraternities defining it the way they want. Okay, in Australia, I found out it's just about keeping a record of your health. In the US, because the industry there shows them what all possibilities are there, the definitions are a bit more engaging. In Canada, again, it restricts to what it understands. So there is a bit of a problem when we go into definitions of these things, and each one has his own English to follow. What